Yeah, lovely. So my name's Erin. I'm one of the clinical lead speech therapists at the Royal Hospital for Neuro-disability in Putney. And we're really excited to be hosting this webinar today. It's a little bit of a follow-up from the free open lecture that we hosted as a SLT team here at the RHN last summer, where we were talking about our experiences of using flavoured foam or Biozoon here. And we wanted just to do something similar. There was so much interest in that initial webinar. The last time I looked at it, I think the video of it had about 1,300 views on our YouTube channel. And lots of people were contacting us for our resources around Biozoon here at the RHN, etc. So we knew that there was a huge amount of interest in it. And we wanted to host this study day, this webinar this morning, and try and invite some speakers from other places working across the UK and with slightly different client groups as well, to start sharing some experiences and learning points really from you know what we've kind of gained from our trials with Biozoon so far. And we've got some fantastic speakers lined up, and we'll just whiz through the plan for the morning in just a second. Oh, why is my screen not moving? There it is. I wanted to give a little bit of background first of all about where I am right now. So this is the Royal Hospital for Neuro-disability in Putney in London. We're not an NHS organisation, we're an independent medical charity, and we provide rehabilitation and long-term care for people with very complex impairments post brain injury or neurological disease. Been around for a very long time. We were founded in 1854. And we have a whole range of services. So we have a level 1 brain injury service with kind of the most specialist tier of neuro rehab. We have a specialist nursing home, and we have multiple specialist nursing home wards providing kind of ongoing care for patients with really high sort of care needs. We have a range of specialist services. So we have 2 ventilator units for people who are ventilator dependent in the long term. We have people here with Huntington's disease. We have a unit for young adults with PMLD. And we also have a neurobehavioral rehabilitation unit as well. This computer's doing something funny. We have a neurobehavioral rehabilitation unit where we're providing neuro rehab for people who've got challenging behaviours as a result of their brain injury. We've got about 225 patients across all of our services. And although we're not an NHS organisation, we work very closely, you know, with the NHS, and the vast majority of our patients are NHS funded to be here. Okay, so this morning, the plans, I'm just going to give a little bit of an overview of the day and just talk a little bit about some of the data that we've gathered here at the RHN. And then I'm going to hand over to Elizabeth Hepper, who's an SLT from way up north compared to down here, who's going to be talking about the article that she's had published about staff perspectives on using Biozoon. Then we're going to hear from Maria, who's going to focus on sharing some case studies and some learning from using Biozoon in acute hospitals and critical care settings. Then a couple of my colleagues here from the RHN, Amy and Christine, are going to be speaking about using Biozoon in the assessment of awareness for patients in a prolonged disorder of consciousness. Then we're going to give you guys a little bit of a break. And then after that, we're going to hear from Rebecca and her team at the Lincoln Ashby unit up in Lincolnshire about using Biozoon in neurorehabilitation. Then Zoe from here at the RHN is going to be speaking about using Biozoon with people with long-term neurological conditions, including motor neurone disease. And then Elizabeth is going to come back again and talk to us about future research sort of questions and ideas. And then at the end, we should hopefully have time for some questions. You won't be able to unmute because this is a webinar format, but you can pop questions in the chat as we go through. And we've got Anna here from our team who can kind of be keeping an eye on that and collating those for us ready for the end. So really exciting morning. Just to talk very briefly, I'm going to assume that everybody who's interested in here today knows what Biozoon is and has had a play with it and used it with patients perhaps. And obviously we know, there's been lots of discussion about the applications of Biozoon, sort of informally for quality of life, rehabilitation, palliative care. It's potentially applicable to any dysphagia caseload. So not just sort of neuro, which is the world that I come from here, but also learning disability, pediatrics as well. So it is potentially got so many different applications. And one of the big challenges, I think, that we all feel to some extent or another with Biozoom is that there is a lack of research evidence. So, you know, we can all get, I certainly get really excited about it and all the kind of, you know, options around it. But one of the big challenges for integrating it into practice is the fact that we just do not have that research evidence there at the moment. Obviously, as I mentioned, there's one paper been published about staff views, which we're very lucky to have Lizzie talking about with us today. But there's nothing published, to my knowledge, so far about sort of patient outcomes or kind of patient data. And as I said, that's why I wanted to host this webinar today, to kind of provide a forum for people to be sharing, you know, their experiences and learning points in the absence of research. I think it's going to come, it's inevitable. And again, Lizzie's going to talk a little bit more about that at the end of the morning. But at the moment, we're kind of in that time where we don't have it yet. With that in mind, I just wanted to talk very briefly about the flavoured foam tastes or Biozoom trial that we've done here at the RHN. I'm not going to go on about it in great detail because we spoke about this at length in the previous webinar, which is still on our YouTube page at the RHN here, if you want to hear a little bit more detail. So we did a retrospective audit of 14 patients who we had trialled Biozoom with here. All of them had some form of neurological injury or impairment or progressive condition, really varied levels of cognition. Some had a tracheostomy, all struggle with saliva management, and a real varying length of time post-brain injury. And many of them had been there by mouth for quite some time at the start of their Biozoom trials. As I said, we retrospectively reviewed kind of medical notes and a Biozoom record form that we had developed here at the RHN. And we basically observed the patient's saliva presentation pre and post trials, any behavioural changes in the patient when given the foam that might give us an idea of whether they liked it or they disliked it, and any, you know, verbal or non-verbal sort of more overtly communicative responses relevant to the person's opinion of having the foam. And for those patients that were set up with having ongoing foam tastes with the ward teams, we reviewed their chest infection frequency for 6 months before that started and 6 months afterwards to see if there was any difference. And then we had 4 patients who were more cognitively and communicatively able, who were able to do a bit of a qualitative questionnaire for us as well. Behavioural responses that we saw, so 32% negative behaviours, 10% more neutral and 58% positive is what we saw in our patient trials. In terms of saliva, which is a question that people often want to ask about or kind of have concerns about with regarding Biozoom, we found that on 51% of trials, there was an observable increase in saliva, so they did produce more. That wasn't for everybody. At 49% of trials, there was no change. So it was about 50-50 basically. And some of the patients who we saw an increase in saliva production, it wasn't always consistent. So some patients always showed an increase in saliva production. That meant we had to maybe give them some oral suction to clear it, for example, but not some of it. But then the next time we tried it, we might not, you know, see much of a difference. So it did vary a little bit within each patient. And in all cases, even when there was an increase in saliva, we found here that we felt we were able to manage that adequately with kind of having Yanker suction on hand in the vast majority of cases. Outcomes wise, so for 64%, which was 9 of the 14 patients, we handed it across to ward staff to have on an ongoing basis. And for 36%, it was discontinued, which was 5 patients. And some of them, that was because the patient said, I don't want it, I don't like it, it's not something I want to have. And the remaining 3 was because when we gave it to them, we either weren't getting any indication of enjoyment or we were getting signs that they actually didn't like it. Chest infection frequency, we didn't find essentially that there was any increase in the number of chest infections after they started having Biozoom more frequently. But a big acknowledgement here is that you know, there's obviously a huge amount of variables associated with the onset of a chest infection, of which only one is aspiration. And there was also no kind of really consistent record of how often the patients had been given the foam taste when it was handed across to the ward teams. And that's likely to have varied to some extent as well. But we did find that the lack of increase, was reassuring. We had a range of sort of overall sort of trends in terms of comments and feedback that we had from patients. About 71% of the comments were positive, such as saying, delicious, I haven't eaten anything for a year, this is amazing. And many of the negative comments that we had tended to relate to a change in the experience of flavour, so describing it as artificial or nasty tasting. So the benefits that we've found here is obviously giving people who have sort of been chronically ill by mouth, which is the cohort that I'm talking about here, giving them that enjoyment of taste and flavour for some people. And sometimes we found that was the case even in situations where we might not anticipate it. So a couple of patients we handed it over on an ongoing basis and who were enjoying it had an inflated tracheostomy cuff, which can massively impact your sense of taste, but still they felt that they got enough from it to want to keep on doing it. We can assume that it's a lower aspiration risk compared to a bolus, potentially quite significantly, just because of the volume of fluid that you're introducing to the mouth being so much smaller. You sort of got the skin of the bubbles, which is carrying the flavour, but it's a much smaller volume. And we know obviously that in terms of whether somebody's going to develop an aspiration pneumonia or not, if they do aspirate, volume is a significant factor as to whether that's going to cause a pneumonia to develop or whether the body is just going to deal with it. It can be for any liquid. So in terms of kind of the options for personalizing it to the individual preferences, is really huge. It can be a great way to work on choice making and sort of basic communication functions as well. And also, social participation, sharing that with family, sharing that with friends as well. Risks. There's obviously a tiny amount of residue. It's not a zero risk option. I think we can recognize that. I think we have to be cautious with claims that there is no bolus or that the bolus disappears in the mouth. It doesn't, because if it did, you wouldn't be able to taste it. So there is a tiny amount of residue there. It's a smaller amount, as we've just said, but you are introducing something into the saliva that wouldn't naturally be there, that might contain sugars or other things. The impact of that, TBC, I think it would be amazing to be able to explore that. Saliva management, as I've mentioned, it definitely causes an increase in saliva for some people. And, that's a normal physiological reaction to having taste and flavour in the mouth. But for our patients with severe dysphagia, it's how they then manage that saliva safely. And does that saliva increase pose a risk to them in terms of chest health? We've found, generally speaking, that we can manage that with Yank suction. But we're in a hospital, we always have that on hand. It's something to be considered for your individual patients, how you can manage that. And in terms of soya, which is one of the ingredients in the stabilizing powder, again, that's an allergen, so it's just something to be aware of as a possible risk factor. So overall, our kind of view here at the RHN is that flavoured foam tastes can play a part in enhancing quality of life in some people with severe dysphagia. Not everybody likes it and everybody wants it, but for those people that do, it can really add something to their either their perceived quality of life or their self-reported quality of life. And for those patients, flavoured foam might be a halfway house between being nil by mouth and EDAR, eating and drinking with acknowledged risks. It's a case of kind of trying it if it's appropriate and basing it on that individual patient, whether it's something that benefits them or not. Okay. And as I've said, we need more research and more evidence to kind of support our decision making and our use of this as a clinical tool. Alrighty, so whistle stop tour there briefly through some of the data from us here. Off we go. So I'm going to hand over to Elizabeth Hepper, as I've said, who is a speech and language therapist from Cumbria, Northumberland, Tyne and Wear NHS Trust. So over to you, Lizzie.
Great, thank you very much for having me. I'm just trying to get my, that's perfect. Just saying that I couldn't override your screen share. So it's just letting me put mine up now. Hopefully you'll be able to see that now. Great, so thank you everyone for the opportunity to speak to you today. As Erin said, my name's Lizzie Hepper and I'm a speech and language therapist working in the area of neurorehabilitation in the northeast of England, and I also work in a level 1 service. Today we're hoping to use Mentimeter to get some of your thoughts as well and have a few interactive opportunities during today. So I've put the link in the comments, but there's also the QR code and code on the screen. So I'd be grateful if you could either log on a smartphone or on another window of your computer. So today I've been asked to share a project that I completed with the support of my supervisor, Joe Patterson, as part of an NIHR funded internship, which explored healthcare perceptions of stabilized edible foam with adults with severe dysphagia. So hopefully you'll find that interesting. Just to start with a bit of background, as I'm sure you're all aware, and this isn't new to you, but there are many conditions that we work for patients that we work with that have swallowing difficulties associated with them. So stroke, head and neck cancer, degenerative conditions. But as Erin said, the list can go on into wider populations, so learning disability, pediatrics. For some of these patients, unfortunately, the recommendations might lead to longer term being nilled by mouth, following concerns perhaps around risk of aspiration or choking. And I guess just to start with, how we manage this as clinicians is the first issue to be addressed is often how do we get nutrition and hydration into our patients? So we focus very much on that. And then we might come across some side effects, some physical side effects perhaps, such as dry mouth, and we think of how we can manage that and support with things like oral care or artificial saliva. And once those things are managed, then we might consider the rest of the gap that's left when someone's no longer able to eat and drink, such as the experience of taste. But what about the impact of social isolation, mood, well-being? There's so many other things that a patient might be left or needs unmet after this. So Louis and colleagues in 2002 pointed out that so far the focus of this patient group has been around optimizing physical care, such as nutrition and hydration, and reducing their susceptibility to infections. And whilst this is undoubtedly valuable, there may be other unmet needs, such as psychosocial impact. So if we could turn to your Mentimeter poll, it would be really helpful or really interesting to see where you feel these unmet needs might be with this patient group. So I'm just going to share. Hopefully this will work. So if you can start entering in your poll as there we go, lovely. I can already see some things coming in. Hopefully you can see it on your screens, and I will just share that just so you can see this word cloud that's starting to appear. So yes, we've got oral hygiene coming up, quality of life, meal times. Someone's saying no other options. So this is looking like we have lots of unmet needs. Quality of life is coming up kind of one of the biggest. So that's obviously the one that most people are talking about right now. So there are many, many gaps potentially for this patient group that we may be involved with in helping to meet. Lovely. Thank you so much for taking part in that. Feel free to keep adding to that if you like. We can share the results after the presentation today. I'll go back to the presentation slide. Great. So we found that the introduction of BioZoom created a lot of clinical curiosity for us, thinking that potentially it might help address some of these unmet needs. So whilst dysphagia is widely reported to negatively impact quality of life, relationships and lifestyles, we wondered whether Biozoom could make any difference to our patients. And this clinical curiosity led to a small-scale preliminary project conducted in 2019 and 20, which was a qualitative study where semi-structured interviews were used to gather experiences of healthcare professionals who had experience of working with people with dysphagia. Participants were limited to healthcare professionals so that it was realistic for the timescale and the scope of the project, because it was a very small scale project. But hopefully we hope to allow a range of views to be captured. The inclusion criteria were that not only having experience of working with people with dysphagia, but also having some awareness or direct experience of flavoured foam, of the Biozoom, so that we could gather a bit more in-depth and specific information from people. And the participants were recruited through a regional speech therapy discussion group, as well as snowball sampling. A topic guide was developed for the semi-structured interviews, which was an iterative process, and participants could share their experiences and making sure that we were asking the right questions. As this is such a new topic, it was difficult to know the sorts of questions that we needed to ask. So that was very much an iterative process. And then once all the interviews were completed, they were transcribed and thematic analysis was completed using the principles of Brown and Clark. So the results were that 55 people were contacted via the regional special interest group via email. And from this and other snowballing sampling, we have a total of 10 participants that were recruited, and that 9 of which were from the public sector and 1 worked in a private sector. 9 speech therapists took part and 1 dietitian. The participants worked in a range of clinical areas and had a range of dysphagia experience, with a slightly higher number of participants with experience of the acute sector. And there was a range of qualified experience between 4 and 25 years. So once the interviews were transcribed and thematic analysis was conducted, a second reviewer or a second researcher also independently coded a proportion of the raw data, which was also discussed and verified, and any kind of mismatch of thoughts were kind of discussed and agreed. A subset of transcripts were reviewed by another researcher to further validate the findings and to ensure iterative reliability. Results were verified with 3 participants, again to increase the validity and reliability of results. So the themes that we found were here. So consideration of risk, potential impact, and perceived experience. And over the next few slides, I'll try to unpick a few of the kind of highlights, the main things that came up. So looking first at the theme of potential impact. There was a general recognition of the wide range of patient groups that may be able to use the flavoured foam, as we've already highlighted today. And there was also a wide range of suggestions for the intentions around improving quality of life and it providing an alternative to current practice, which might have included things like addressing behaviours that challenge, that might be associated with people not being able to eat and drink anymore, kind of being able to enhance someone's ability to adhere to swallowing recommendations. So rather than being tempted to maybe have something that they feel might go against recommendations, feeling that that's satisfying them enough. Or it might also have some potential application to therapy programs. So there's a real wide range of potential impact that came up. However, there was kind of an overarching perception that there was a lack of evidence, and hence the theme that it was potential impact. We don't know what the impact is on this patient group. There was also a recognition of the implications on services, so a potential impact for a training need and education on the service too, if this approach was to be adopted. The theme of consideration of risk. So again, this captures the lack of evidence base for us to draw on, and degree of caution that participants spoke about really varied. around kind of clinical decision making. So risks considered included misuse, again, potentially due to lack of training and education, aspiration risk, and a potential negative impact on saliva management, which links up with the retrospective audit that the RHN have completed. Thirdly, there are a wide range of experiences, including both positive and negative, again reflected of the feedback that RHN have shared from their experiences. However, again, there was a recognition of the lack of evidence about understanding the direct impact on patients and family members of people using the flavoured foam. Again, perceived experience, because we haven't yet got that data directly from patients. We're just beginning to, and I know lots of us are trying our best to do that in small ways ourselves, given the lack of kind of published data. So the limitations of this study. So whilst helpful in providing a starting place for building an evidence base in this under-researched area, the main limitations of this were small sample size, and we must acknowledge this. The number of participants was limited to the scope and timescale of the project, and therefore there's kind of limits to how the results can be generalized. Furthermore, the majority of the participants were perspectives of healthcare perspectives, of someone involved in supporting someone with dysphagia. However, it doesn't capture the wider and broader impact and perspective of the MDT. And it also doesn't capture other perspectives of those directly experiencing the flavoured foam. And finally, the study was completed whilst it's still kind of a fairly new concept. It was introduced where lots of the services were in its infancy of introducing the flavoured foam. And these perceptions might change over time with further experience. It's just a snapshot capturing how people are feeling right now. So to conclude, the study identified that there is unsurprisingly more research required. And whilst it was widely felt by participants that there was potential positive impacts, there were also concerns regarding the lack of current evidence, especially in relation to risk and lack of evidence of direct experience of patients and carers. So I'd like to thank you for listening, and I welcome any comments or questions.
I've got a few minutes now. Does anybody have any questions they want to pop for Lizzie in the chat? So we will have time later for questions as well, if anything occurs to you as we go through. I'd certainly be really interested, Lizzie, to at the end, when you've had a chance to look at the Mentimeter stuff, to see what it all is then. That'd be really interesting. Thank you so much for sharing that. Yeah, I think like you say, it's a really good starting point, and it sort of, it highlights, doesn't it, where some of the gaps are, where some of the needs are, and this need for more research, more evidence to kind of support our clinical decision making with this tool. Okay, so hang on, we've got a what? Sorry, Q&A. Amazing. So somebody's asked the question, is there any plan for research into pediatric populations? And that's from Claire.
Not that I am aware of. I would like to think that the pediatric community are interested. I have been people have been in touch asking about it. I think they found that there are other things to consider for that patient group, but I think it will be a really valuable thing to be explored, because, like we said, there's a wide reach, not even for people with just dysphagia, people that aren't able to eat and drink for other reasons. There's even potential for wider scopes, so kind of obstructions and things like that. Yeah, I think as pediatrics is way out of my skill set, I don't feel I can pioneer that one, but I'd be more than happy to hear if someone's interested in starting out. Kind of, if you want to get in touch with me, I can see what we can do to support.
Thanks, Lizzie. There's another question. Where do you see this research going further? And is there anything currently underway? Are you going to talk about that in your next talk, Lily?
Yeah, we will do. And I think it'll be, again, a great opportunity to get more of your feedback, because I think we want to work out what the priorities are, and I'll share some of the reflections and some of the avenues that I've been exploring, because I think it's definitely something that we need to keep digging deeper into, really.
Yeah, absolutely. So yeah, so Lizzie's going to do another talk to kind of finish off the morning about kind of thoughts and plans for kind of future research from the work that she's doing at the moment. So that will answer some of your questions about that, I think. Somebody else saying, have there been any concerns raised about offering this intervention to cognitively impaired patients who are unable to accept the lack of known risk to consent? How are we sure this intervention can be offered in best interests at present?
Are you able to do that again for me, Erin?
Sorry, can you see the Q&A?
Oh.
Can you open it at the bottom of the screen?
Yes, this is Emma's question.
Yeah.
Mm-hmm. Have there been any concerns raised re offering intervention to cognitive impaired patients who are unable to accept? Yeah, I think that's a particular challenge at this stage, because we don't have much evidence base to go on. I would imagine you've had similar experiences, Erin. When I've had direct use of it with patients clinically, it's always been quite an open, overt conversation with the MDT as well as the patient and their family, kind of just to help them make a choice whether they feel that it's the right thing for them to try.
I think in my experience, I think it's the same as with any decision making around oral intake and management of that. Is always completely individual to the patient, the person, and based on a detailed, thorough, clinical assessment, and you're using your clinical judgment and clinical reasoning, I suppose, to try and establish where the risk is and how great that risk is to the best that we can, because as we know, that's really hard for us to do with any clarity about, anybody that we're starting an oral intake. There are so many risk factors that we don't know about, unless we're doing an instrumental assessment. And even then, it's a snapshot in time. It's not reflective of, we know all of this. So I think it's absolutely a challenge, and more evidence will help with that decision making. I think at the moment, personally, I approach it on a patient by patient basis and use all those transferable clinical skills, that we use for any dysphagia assessment and decision making about recommendations with the patient, with their family, with the MDT, or in their best interests. Yeah, for that capacity. There's loads and loads of questions coming through that are quite sort of broad and general. So what I'm wondering is, what we might do is move on and go through our next couple of talks, so that we will have time at the end for questions. And it might be that as we go through the morning, some of those questions are answered. And then at the end, all of us can kind of join in with responding to those. So if we pause the questions there for now, obviously feel free, guys, to keep writing them in the chat, but we'll come back to them later. And we're now going to move on to hearing from Maria from Barking, Havering and Redbridge University Hospitals NHS Trust, who is going to talk to us about the use of Biozoom in acute and critical care. Over to Maria.
Hello, thank you. Thank you for having me. Apologies, everyone. But anyway, my name is Maria. I'm one of the speech and language therapists working in critical care at Queen's Hospital and at King George Hospital, which is just outside London. And I'm basically just gonna share my experience of just using Biozoom within our team. So basically, how we started is this time last year, actually, I attended one of the webinars provided by RHN, and they talked about Biozoom there, and it was something I had never heard of before at the time. So I obviously thought it was within our team to buy it, and we basically got the funding from the therapy managers, which was quite straightforward. They were pretty happy with the rationale to buy Biozoom because it's a fairly inexpensive device in comparison to other stuff that are around as well. So that part was quite easy for us. And then we developed an infection control protocol, which is on the slides, and I've shared it quite a lot with a lot of people that have contacted me already, and I'm happy to share it after this webinar as well with everyone who's interested.
Maria, the email hasn't come through over the presentation. I wonder if it's getting blocked because it's too big, either from your end or ours. Do you want to just give us the key points of what you're in? Can you give us the key points of your infection control protocol, just for interest, and then we can share the slides afterwards?
Yes, 1 second. It is adapted from actually the one you shared with us. But I guess the main thing and the main difference is that the silicone tubing for us is single patient use. So on the Biozin website, it says that obviously you can use it with a lot of patients as long as you wipe it down with a Clinell wipe. However, our infection control team would not really approve this, which was quite a challenge for us. So we came to an agreement that we can use it many times, but just with one patient. And obviously, once the patient goes, we'll discard this. So this is the main point, I guess, for us. And if you're having similar difficulties with your infection control team, it may be something to consider. And another thing, I guess, to consider about this is the cost, because one pack of about 4 silicone tubes is about £8 to £9. So it's something to consider in terms of like funding and how you're going on about this. So this is in terms of our
Maria, you've frozen, I'm afraid. I'm assuming that Maria's frozen for everybody else as well. Oh, I think we might have lost Maria. Let's just give her a second and see if she can come back.
infection control policy, and we're also seeing this in terms of how to use Biozin, and obviously what patients may look at the email just to see if it's loading. Give it a go. Oh, it opened, perfect.
Oh, here we go, screen share. Maria, we just lost you for a little minute there.
Oh, can you see this, everyone?
Not yet. We just lost the sound for a second there as well, Maria. You were talking about how your hospital's infection control team wanted you to use the single, make the silicone tubing single patient use and the cost implications of that.
Yeah,
to consider. And then I think we kind of lost you shortly after that.
Oh, fine. Can you see my screen now? Because I think I shared it.
We can't see the, it says you've started screen sharing, but we can't see the presentation.
Oh. Let me try one more time. I shared it again. Can you see this now?
No, it's not coming up.
Oh, that is annoying. Shall I?
Sorry, Maria.
Is it just a black screen?
Yeah.
Oh, okay. Shall I talk through it then? Because I'm not sure what else to do.
Yeah, no, definitely. If you just come if you can talk through, and then we can share the slides afterwards.
Perfect. Yeah. What I was saying in terms of the silicone tubing is that for us it is single patient use, so we can use it multiple times with the same patient, because our infection control team would not really approve it being used with many patients. Although the Biozin website says that you can do that if you just wipe it with a Clinell wipe, basically in between. And something to consider in regards to that is the cost, because one pack of 4 silicone tubes is about £8 to £9. So we have actually started using Biozin only since August, so it is fairly new for us as well. So I've just been collecting some very basic data just to see how we're using it within our team. So far we have used it, at least at the time I did the slides, we used it with about 18 patients in about 7-8 months. And quite a lot of this population is patients in critical care. and we use it a lot for swallow as part of their swallow rehabilitation as well, which hopefully is going to be reflected on the case studies I'm going to talk about. So as a team, we're using, it's mainly speech and language therapists using Biozoom. If we've got students, they can use it as well. And there has been times that we have introduced it to the family if they're happy to use it with the patient too. It's quite variable how much we use it or how often we use it. Depends on our capacity, obviously, as well, but at least in critical care, the aim is to do it once or twice a day. Again, depends on our capacity. And we have tried it with a lot of things. We have tried it with juice, smoothies, coffee, even hot chocolate. We've tried it with coconut water and even alcohol for a patient of ours. So I'm gonna talk you through one of my case studies. So her name, let's say, was Helen. She was a lady in her late 60s. She was retired, very independent before coming to the hospital, had a really big family. So she came in with some symptoms that basically led to her Guillain-Barré diagnosis. And she was intubated and ventilated for about a week. And after that, she had a tracheostomy. And she had a very long hospital stay. It was over 100 days. So she was in the hospital for a very long time. So some of the key clinical events, I guess, is during her admission overall, she had multiple lower respiratory tract infections. She was not suitable to do cuff down trials or inline PMV trials. So when she was still on the ventilator for quite a while because of her chest stages or high secretion load or other things going on medically with her. Eventually, when she was a bit more stable, we were able to try a speaking valve, but it was very short periods when she was on the ventilator because of her fatigue. And overall, I guess it's important to know she was very difficult to wean from the ventilator. So in terms of speech and language therapy, we were involved with her from the very first week of her admission because of her diagnosis. And during her hospital stay with us, she had about 3 fees that all showed that she had moderate pharyngeal stage dysphagia. And based on the penetration and aspiration scales, she was a silent aspirator. So after her first phase, which was at the start of her 3rd month, we decided that it would be suitable to start some swallow rehabilitation. And as part of this, we thought it would be great to actually start using Biozoom with her as well. For, again, swallow rehabilitation, but also for quality of life purposes, as he had been ill by mouth for quite a while. So we were using this with her every day. We were trying to at least, we would use about 5 to 10 teaspoons, and that would vary depending on how much she wanted. She did have capacity as well. So we would use it mainly when we were doing cuff down and inline speaking valve trials. However, because of her medical stages, loads of times she was not actually suitable to do speaking valve trials. So we would try Biozoom even with cuff up, and she did say she was able to taste it, so she was able to enjoy it and get the flavor, the taste of this. We would often stop Biozoom depending on what was going on with her medically. She was a very complex, fragile patient. So depending on her chest status, she had some chest pain as well, that would vary. And as you would expect, obviously, she was in the hospital for a very long time, so her mood was low. So it may be the case that she didn't want to do it. So it wasn't a case of we would stop Biozoom because we thought it may have caused her an aspiration pneumonia. It was more because there was quite a lot of things going on medically. So it was a case of maybe we need to stop for now. This is not a priority. And we would continue when she was again a bit more stable and she was interested in doing this. The family obviously were aware that we were doing this. However, we did not leave the device there because, as I said, of her variability. So we did not leave it with them to do when we were not there. In terms of what we tried lots of things. We tried black and white coffee, blackcurrant, orange juice, apple and mango juice. And so it was our first patient that we tried alcohol. We tried pink gin because it was her birthday, and she just really wanted to try her favorite pink gin. And the doctors were happy to give it a go, just a few spoons, and she actually really enjoyed it. And it was lovely to see, and the team on the ward were also very pleased with how the session was as well. In terms of some of her comments, depending on what we were trying, sometimes she felt that it tastes a bit tinny, or that the taste is not as strong, which is the main comment we had from a lot of our patients. They have said that, you know, the stronger the taste, the more you can actually taste it with the bubbles. So I guess it's quite important to consider what we're trying with them. And she did feel like she had something to swallow once the foam dissolved in her mouth. So again, something to consider from a swallow rehab point of view as well. So now I'm going to talk you through our second case study, which is, let's say, John. So it was a gentleman in his early 70s. Again, he was very independent before his admission to the hospital. And he came in for a laparotomy because of a perforated duodenal ulcer. So he had multiple complications during his hospital stay, multiple abdominal drains, washouts. He had 3 cardiac arrests. He was fed through a TPN, and he had a tracheostomy as well. So again, he was quite a complex patient. So he was in the hospital for a significant amount of time. We had a lot of discussions with the doctors about using Biozin with him when they felt that he was approaching maybe the end of his life, but the medical team at the time wanted to keep off, let's say, while they're still actively treating him, which was quite interesting. And then this patient pulled through, and he was able to get off the ventilator, and he was doing speaking valve trials, and he was actually doing really, really well. So we all felt from the MDT, the physio-dietetics, occupational therapy, and they, you know, our MDT has seen how we're using Biozin quite a lot. So they have seen how it can benefit our patients. So they felt, and we felt, that, you know, there is a benefit here to revisit using Biozin for this patient, for his quality of life, but again, to help with his motivation. So this patient was nil by mouth as per the surgeons because of the gastro stuff that he had going on. And as I said, he was TPN fed. So we had discussion with the doctors basically and the medical team treating him about the pros and the cons. So obviously it was quite hard because, as everyone has mentioned, there's no research out there on Biozin. However, you know, we felt that the pros are his quality of life obviously could improve. He would get some taste out of something that he enjoyed. Potentially it could help with his motivation to enjoy it, with his physical rehab as well a bit more. And obviously it might offer him some benefits in terms of his swallow rehabilitation, because we didn't want him to lose this skill because he was nil by mouth. And some of the cons that we may be aware of is it might increase some saliva production, as everyone has mentioned. Could this increase the risk of aspiration or obviously going to his stomach? Quite unclear. But we had this discussion with the medical team, and we felt that, you know, there is a benefit here. So we sort of agreed, let's try some small trials, because the pros actually outweighed the cons in that case. And again, John had capacity, so we were able to explain to him what this device is, what we wanted to do, and he was happy to give it a go. So we agreed with the medical team that we would try about 5 teaspoons a day just with speech therapy. So we tried like orange juice and orange squash, but again, he preferred the squash as other patients because the taste is very strong in comparison to other juices maybe. But we were very much led by the patient in this case as well. Sometimes he wasn't keen to do it. He thought sometimes it's quite weird that this is a foam, and he preferred focusing on his physical rehab as well. So that is absolutely fine. But if, you know, it is something that it was there for him if he wanted to get some taste out of it. Overall, I would say our patient feedback has been very positive. It depends on the taste. So patients have reported that it doesn't taste as good, or the taste is weak, depending on what we try. But otherwise, they have enjoyed it, and they pretty much everyone we have asked, they would suggest using it again. And I quite like this quote from one of our patients. He basically said that it motivates me to do my swallow rehab because tasting it means I want to have it for real, which I think is lovely. I wanted to share a patient video with you. I can try again after I finish, because it's patient feedback and it's lovely to actually hear. But some of our reflections, I guess, as a team is we found that squash without water is much better because the taste is very strong. Again, strong flavors, experiment with your patients, see what they want to try. If they didn't like it the first time, it may be that they might prefer another drink. You can try hot drinks. We have tried hot chocolate, and the patient actually said that they can taste hot as well, which is lovely. Present cases at meetings to raise interest. We have presented how we use Biozoom during our MDT meetings. We had it during our swallowing awareness day, and people could try it. And now I get nurses coming to me asking me if I think this patient is suitable to try it with, which I think is lovely. You may need to advocate for it. As I said, there is no research out there, but if you feel like it might benefit one patient, it would be worth having a discussion. People don't know what it is, so show it to them, have them to try it as well. And, you know, obviously use your clinical reasoning, outweigh the pros and cons for every patient. And we found that frequency varies. So obviously there is no one size fits all. So for some patients, we might try just a few teaspoons. We might do more with others. Depends if they have capacity as well, if they are enjoying it, how they're presenting with Biozoom, if they need suctioning after, obviously, as well. So there is a lot of variables here. But yeah, I would say, you know, if you feel like a patient is suitable for it, just give it a go. Obviously discuss it with your team if you're not sure, but I think it's a nice toolbox to at least have in our speech therapy toolbox kit. And I had my contact details that I'm happy to share with you, obviously, after this webinar. You still can't see my slides, Erin?
No, sorry. What we'll do though, Maria, because I think it'll be amazing if we can try and get that patient video. So we've got another talk now here at RHM with some of the team from here, but we can try and have a go in the break and see if we can get the video going so that we can show everybody after the break.
Just to double check, I tried again to share my screen. You still can't see it?
No.
Okay, yeah. No, that's unfortunate because because it's a great video. We can give it a go after. But yeah, if anyone has any questions, please let me know. And I'm happy. We'll share my slides after this as well.
Absolutely. There's a couple of questions. Some people are asking about fees. So then have you or anybody, feel free to pop in the chat if you have, tried Biozoom with fees kind of live to see the impact on saliva?
So we actually haven't, but it is something that we want to do. So I think it is in our plans in the future. If we have a patient that is suitable for Biozoom and we think they're also suitable for fees, we definitely want to try it. I'd be interested to hear if someone else has already.
Lizzie, were you going to add something?
Yeah, one of the participants in the study I did, I think they had looked at it on fees. Someone having the Biozoom, and I think they saw that they could see it sitting around the pharynx, some bubble residue. But I think again, it's understanding what that's showing us and what the implications of that
what it means for the patient.
Exactly, and kind of our understanding of aspiration and aspiration pneumonia are two different things. And so I think it has been done informally and just from someone out of clinical curiosity, I think. But I think in terms of knowing what that means for our management and moving forward is a very separate thing. I think in that individual, or that team, I think it evoked quite an emotive, a bit like oh, it's there. This means it has a huge impact on our clinical decision making. But I think it's, and I think that's understandable. But I think this is where we need more research, and it's working out what the priorities are, because it's one thing observing something and it's another thing understanding how that informs decisions.
Yeah, absolutely right. I did have somebody who contacted me a little while ago and had said that they had tried it on a video fluoroscopy, and I didn't quite know how they'd done it, but they'd basically, I think, mixed Omnipaque up into a drink and then tried to make the froth with the Omnipaque and then given it to the patient, and they said we could see a bolus, and I was like, but is that what you can see? I'd be so surprised if you could see it clearly on a video fluoroscopy, because the quantity of the actual juice itself is so small. But I wonder whether, because it probably caused a saliva reaction, that possibly then whatever was in there of the Omnipaque mixed with, you know, their secretions, and that's what they could see. Also, I don't know how, I mean, anyone else has tried making using thicker liquids for Biozoom. So we've had some trials here as a team where we've got loads of like savory things to try, and we found that anything that's thicker doesn't really froth up very well at all. So things like gravy, like to try and give someone a savory taste, we actually found that it was really hard to get bubbles out of the gravy unless you dilute it so much that it just tastes salty, and that's all you get from the flavor. So again, I'm not sure how successfully frothing it up with barium in it would have actually been, but yeah, I think it's something to explore, isn't it?
We found that Bovril's been a big.
Sorry, Lizzie.
Sorry, we found that Bovril's been a big hit with some people that crave savoury things. So I think anything that's liquid or broth, things like that.
Yeah.
We haven't tried thicker things, but if it's a liquid form, I think there are other thin, kind of like cuppa soups, those sorts of things. I think they work okay.
We did play with some of those, and some of those have got little herbs in them. So actually, if you're giving them this, you can't really get the herbs out and not get the herbs in the foam. So I think it's working out specifically, what flavors, and which is, we've been trying some stuff. But making a stock, that's thin seems to work quite well, doesn't it? As long as there's no bits. Okay, someone else asking for you, Maria. Have you been asked to create a standard operating procedure / SOP for the Biozoom, as well as an infection control policy? I've been asked to write a SOP, which is quite lengthy and complex and based on an acute stroke unit. This then needs to be approved by a CDG board or governance group for SALT, and then onto a wider policy group. This seems like a lot for us to do for something that isn't very invasive, or brackets relatively high risk compared to other interventions we may introduce. We've had the equipment for months now and have not been able to use it. I'm considering challenging the need to do a SOP and propose we start a trial or pilot of the Biozoom and then consider a SOP if we need to roll out more widely. If anyone has had any experience with SOPs or trends in any form, please let me know. And Naomi's put her email address on there if anybody wants to get in touch with her. Maria, did you do a SOP for yours, or was the infection control policy enough for your trust?
So for us, it was enough. We didn't really face any challenges, but as I say, we only introduced it on a local level. We introduced it with our speech therapy team, and then obviously if we feel like a patient is suitable, we can have a discussion with the team on the ward and introduce it to them after. But we just went with our infection control protocol. I was not asked to create anything else.
I think it's really mixed, isn't it? And certainly, I said we've had so many emails here off the back of our open lecture from last year, and it seems to be a really mixed picture across the UK, really, in terms of how much different hospitals and different teams are being required to put together. And some people, it's been quite relaxed and it's been quite easy for them to try it. And for other teams, they've had to jump through many hoops around things like infection control and, SOPs and those sorts of things. So I think it is a bit mixed bag. Somebody said on the chat that they've been asked to do a SOP and that they will message you, Naomi. So that's great. I'm just very aware of time. Again, loads more questions coming through on the chat. We'll compile all these together and answer as many as we can at the end. I'm just going to hand you over now to two of our speech and language therapists here from the RHM. So we've got Amy Endicott and Christine Gormley, and they are going to share a talk with us all about using Biozoom in the assessment of awareness for people in a prolonged disorder of consciousness. So I'm just going to hand this over to these guys and let you introduce us.
Okay, well, hi everyone. As Erin said, we are Amy and Christine. We are two of the speech therapists that work on several wards, but we work on Devonshire, which is primarily our PDOC unit. Okay, so first, just to have a little recap on PDOC and what it is. So PDOC, the operational definition, is remaining in low levels of arousal for more than 4 weeks. And this arises from widespread damage or disruption to brain networks as consciousness comes from this whole brain function. For consciousness, we need both wakefulness and awareness, and it's important that we don't get these two things conflated. So wakefulness is a state in which the eyes are open and there is a degree of motor arousal, whereas awareness is the ability to have and the experience of having any experience of any kind. And there's a spectrum of presentations that we see within our PDOC cohort. So at the bottom end, we have somebody in a vegetative state. So those responses are primarily reflexive. They may respond to things in the environment, but these are generalized. They're not specific at all. Then we move up the continuum to minimally conscious state, where we might start to see localizing behaviors. And this person starts to show some awareness of the environment and themselves, including something about their self-history. And then we move towards emergence. So we see a consistent pattern of responses. And this demonstrates that somebody starts to have a kind of static understanding of what something or someone is, its purpose, its place in the world, and how it interacts with other things. So working with people in PDOC is becoming increasingly prevalent, especially for speech and language therapists across a variety of settings, as medical advancements have kind of come so far.
Might have to. Okay.
Perfect. Okay. So thinking about PDOC assessment. So in PDOC assessment, we look at both spontaneous responses, so things that happen for no reason, versus hierarchical responses to specific stimuli. And this can be both things in the environment, so things like a way a person responds to somebody slamming the door, or things that are specifically administered, so showing photos of favourite people. These assessments can be both formal or informal. So the formal ones we've got here, things like the CRSR, the WIM, the MATADOC, the SMART, these are slightly more prescriptive and have a protocol. Or we can be more informal using things like a personalised programme, which is a set of key tasks relevant to the patient's ability and personality, which we repeat to track change over time. Or we can be even looser and more dynamic, and maybe we follow the patient's lead and scaffold up and down during our session to explore their ability. We use here part of the Putney PDOC toolkit, which is a really nice guide, which kind of gives us a bit more information about these informal tasks and how to measure them. The RCP guidelines from 2020 recommend for assessment that we have both these standard and non-standardized approaches, and that actually this clinical assessment, is the cornerstone of PDOC diagnosis. Oral trials, and Biozoom particularly, would sit within this kind of specific administered stimuli and informal contextual assessment.
So before we get into Biozoom specifically and using oral trials, we thought we would include some information about swallow in severe brain injury and in our patients who are in PDOC. So as we know, swallow requires complex sensory motor integration involving multiple cortical and subcortical areas. It has voluntary and reflexive components, and in patients with severe brain injury, there may be abnormal primitive reflexes that are present or impaired, or they may be heightened as well. So a patient may seem to manage a bolus, but they may only do that using reflexive behaviours rather than voluntary, and there may not be any clear awareness or enjoyment. They may have a reflexive swallow, but it may be impaired as well. So there may be differences in how that presents. And as we know, we may want to explore eating and drinking to support our overall diagnosis and provide ideas about prognosis. And the ability to eat and drink is a good prognostic indicator. But as we go through the rest of the slides, we'll constantly refer back to our need to assess with caution in swallow, in oral trials, in Biozoom, and in patients in a prolonged disorder of consciousness, and especially So specific to considering how we're going to assess someone's swallow in PDOC, we need to consider what we're going to do. So we've composed this slide about the use of Biozun or doing oral trials in eating and drinking. So with Biozun, as Erin has said earlier, it's not a zero risk option, for example, with increased saliva, but there is a lower risk on chest when we're comparing it with oral trials. So the material dissipates and many of our patients have vulnerable chests, and there's less bacterial residue versus something that actually is yogurt, for example. It provides that sensory input, but it is also something that has got more impact. We can use it with people who may have oral aversion or any problematic oral behaviors. So lots of our patients have hypersensitivity, or they may not open their mouths to oral care. So we could use Biozun with oral aversion to introduce something that's pleasant, and that may help. Food and drink might be too risky in this example, so then Biozun, as it's a small amount of a safer consistency, it can also be better controlled. It's not something that you would need to suction in the same way as you would have with yogurt, for example. We find that it gives an increased stimulus for oral behaviors. We can also make it, there might be more increased sensation or flavor. So we can get a really strong flavor with something if someone is particularly hyposensitive as well, if they don't have much response to different tastes. So it could be a really strong squash, for example, that can really stimulate that. This foam as well, it can be more cohesive as well, so it stays on the spoon, so less chance of anterior loss. It can be well personalized with a range of flavors, so we have more options when we use Biozun, from things like Guinness Biozun trials, which we've done, to hot chocolate, to gin and tonic, as mentioned before. And again, it might be useful as we can use it in a repeated way. So with our oral trials, we have to wait for a swallow. But as with Biozun, it's something that we could maybe continue to do without having to wait for the person to swallow every bolus. So it's helpful in building that functional feeding activities, and it gives us a chance to look for other communicative responses as well. And then finally, it could also be seen as something that's more like an assessment, more like an intervention rather than eating and drinking, which brings up lots of questions in terms of ethics and best interests. And it possibly can be more boundaried in that it is an assessment, and it can help us to manage expectations with the MDT and also with family members as well.
Lovely. Okay, so who would we do Biozun with on our PDOC caseload? So as part of our standard PDOC assessment and intervention here at Putney, we would be looking at ability and response to oral intake, and Biozun fits really well within that. But particularly, we'd be thinking about this for patients who cannot demonstrate emergence, but we feel like they maybe have something else there that we're not picking up on. So we know there's lots of issues with emergence criteria and linguistic and physical components of this. And oral intake actually allows another way to explore cognition, navigating these barriers. And we might see behaviours compatible with emergence during a Biozun task. Many of our patients have visual and hearing difficulties, so they may not get sensory input in these domains. They may become slightly sensory deprived. So again, having something orally allows another route in to increase that repertoire of behaviours demonstrating what somebody can do. Biozun, obviously, for assessment is still possible even if the person is severely physically impaired, so they can be fully dependent and we can support them with that. Oral intake and kind of oral stimulus is known to have a far more emotive response. So where there are people sometimes in PDOC presenting with much more emotional responses than necessarily kind of functional cognitive ones, if they have a degree of internal distraction or preoccupation that stops them engaging in other types of assessment, oral intake and Biozun could be emotive and maybe elicit a wider breadth of responses. And of course, helping support our compliance with mouth care and maybe a motivating way in for us. And Biozun also provides sensory stimulation, so it's twofold for us as SLT. So we've got here that it helps us assess, but it also gives us information and helps us support regular sensory stimulation. And I've also got here people that are kind of pre-morbid foodies. So obviously food and drink means something different for all of us. And actually, if that was an important part of somebody's pre-morbid personality, we may see more responses. I've put here as well the kind of swallowing assessment that we look at as part of the PDOC toolkit here, and also the guidelines for speech language therapists working within PDOC. And both of these documents have got some really helpful information in terms of completing oral assessments. Okay, so thinking practically about how we would do it. So this are things that we've put together based on our experiences of using Biozin with our PDOC patients. So ensuring that the setup is good. So they need to be optimized medically. They need to be comfortable. If they've got a trachea, have they just been suctioned? You know, are they able to engage as much as possible? The activity location, so trying different places, you know, thinking about being somewhere like the canteen where there's lots of noises and lots of smells, that might be helpful, or it might be a hindrance, versus being in the pub with friends versus being in a hospital space. Thinking about preferences and dislikes. So sometimes we know that people actually respond more to things that they don't like. So obviously we don't want to overly agitate them, but if we can get different flavors, different tastes going, we may see an increased level of response. And of course, the people involved. So family can be really helpful because they know the person well, but also they might find that a little bit uncomfortable. Kind of trying to feed someone is a bit different to a normal family dynamic. And nursing staff, some of our patients have really good relationships with nursing staff. They're used to nursing staff being very close to them. So it might be worthwhile having nursing staff actually supporting us to administer the trials. In terms of assessing it, we need to think about a structure and protocol. So it's important that we have repeated practice and we're kind of using the similar tasks so that we can track change. We need to think about being time bound. That's really important again, so that we can track change clearly, and that we actually have a structure and kind of rationale to what we're doing. We can do it within our personalised programmes, which again, as I explained before, are kind of a set of key tasks that we repeat over a period of time. In our sensory group, to again change the setting into kind of a more social situation, and fit it within a behavioural framework. So we can fit, there are sections that look at oral responses in the CRS, for example, so we could fit it within that, but we need to make sure that we're capturing what we're doing. In terms of documentation, we would obviously complete this on our personalised programme. The PDOC toolkit has an SLT assessment sheet. We could develop our own behavioural checklist, again, looking for those key behaviours and seeing if they are replicable and consistent over time, because that's what lets us know about somebody's cognition potentially changing and that trajectory. So the trajectory is really important in terms of prognostics within somebody in a prolonged disorder of consciousness. So we need to ensure that we're documenting that as clear as possible.
So then to map the continuum of responses when using Biozin in our assessments, so we have some examples of VS patient here. So reflexive responses, they may respond to things in their environment, but they're generalized, they're reflexive, they're not specific. As an example, we had a young TBI patient in VS and we trialed Biozin orange juice and some Biozin hot chocolate. Behaviours in response to Biozin were very similar to those at rest. He had some tongue pumping, he had bite reflex. But we also had difficulty with oral access for mouth care, so we used Biozin after we did a desensitization program. We had it quite time bound as well, so over a couple of weeks, 2 sessions involving family as well. And it did help with, we found that desensitization, he did have more, we could access his mouth more consistently, but we didn't see any clear changes in responses. So in the way that he stayed in that VS category, we maybe saw a grimace at one point, but it wasn't replicated. So that would keep, that's why we have the differences here. So within MCS plus or minus, there may be changes in facial expression to different tastes. We might have a grimace or a smile. There may be fixation, tracking, localizing, and then anticipatory responses to Biozin as well. And you may move on to things like functional object use, indicating choices as well, indicating that someone might want more, all the way up to our emerging criteria as well, where there's consistent choice, there's differentiating repeatedly over time, and possible memory between the tasks as well of having the Biozin trials. And then initiating intake and manipulating solid food as well as functional object use. So consistently using a spoon, for example.
Lovely. So here are some of the things that we think are important to consider when using Biozin with our PDOC population. So this obviously eating and drinking is a really normal task for all of us. So hopefully it's more motivating for people, which is why we think it's so valuable as part of PDOC assessment. Again, as you've said, it lends itself really well to context-based assessment, especially for people that maybe aren't able to engage in other ways because of a severe physical disability or language disability or vision. Eating and drinking is really emotive. So people and families may have very kind of personal, specific cultural views around eating and drinking. So we need to find out about these. What does oral intake mean to the person and the family? We need to ensure that we consider best interest decision-making around CAN-H. So be aware of how our input as speech therapists and starting that process of looking at oral stimulus can be relevant. It's a multisensory input. So again, it's really valuable as part of our sensory stimulation programme. It has a level of reduced risk. So this might help clinicians feel more confident when working with people in PDOC who maybe for some people are more impaired than the normal kind of standard clinical caseload. So it's a really nice way of kind of getting used to kind of working with people in a prolonged disorder of consciousness and looking at oral intake in maybe a kind of safer way. Hypersensitivity and mouth care. So we know lots of people in PDOC have difficulties with mouth care and sensitivity. So how is that oral stimulus impacting that? We need to monitor and ensure we monitor throughout for any negative impact, because that can be really challenging to manage. The swallow presentation. So is their swallow presentation cortical or is it just primarily reflexive? And we need to think about what are the issues with feeding just a reflex for patients and families. The soya allergy, of course, always check that, it's really important. And future planning. So what will the follow-up be if this is something that we think the person might need longer term? And if it's not appropriate, how do we address that with all the relevant stakeholders? We need to be clear from the outset about what our aims are. And education. So this is a new intervention. It requires education to care staff and family about the setup for safety, but also for the aims and the purpose so that everybody is on the same page.
Thanks. So Amy's already touched a little bit on working with families. So obviously families play a key role in our assessment and diagnosis of patients with an disorder of consciousness. We meet with them regularly, we constantly discuss the patient. As Amy said, we can get a bit of background on how they are in terms of pre-morbid likes, cultural things as well to take into consideration. They often spend more time with the person as well. So they might see different things that we don't. So we do often get together, make it quite collaborative. They're able to make their observations. We have checklists that they can do as well, just so that they can feel like they are involved in the person's assessment as well. Families do want to be involved in something that's quite interactive and quite meaningful. It provides a bit of social interaction. It's something that's very motivating for families as well. There may be different responses with different family members there. There might be a bigger response or turning towards a certain family member's voice. But it also provides ideas for something for them to do. So it involves touch, taste, smell as well. And then in turn, this allows the MDT to provide information on current responses and abilities. So it acts as a way of educating families, which we know can be tricky at times in patients in prolonged sort of consciousness. So for example, the patient on the previous slide who was in BS, his mum was involved in the BioZoom trials. And that provided her education around his reflexive oral behaviours. And it was discontinued as a part of our assessment tool, and it was contributed to in our assessment summary and our prognosis. But it was made very clear to her throughout that it was something for assessment and it was discontinued. But again, so it's something that we know families may have unrealistic expectations of recovery, and the impact on families should be considered if you are considering BioZoom trials. But again, it's case by case, individualistic, it's a best interest decision, but it's something that needs to be used with caution, with clear purpose, with rationale, as it could raise family expectations. So it's something that's for assessment only. And then if we're moving on to, if it does become something that might be considered for post discharge when we're no longer involved, it may provide some long-term monitoring of change and may contribute to their PDOC reviews. We need to also consider funding for the device and the consumables. So where will that funding come from? Will it be family that provide the machine, or will it be the ICB versus any insurance funding? But this will need to be agreed in advance. We need to provide family training and education to external agencies, so wherever they are going next, they may not be aware of what Biozone is at all. And then clear guidelines for all parties involved need to be completed.
Great. And just to finish up, I suppose, like any intervention in PDOC, we need to consider best interest, as the person themselves was unable to tell us what they want. So we know that oral intake and starting that assessment process has a complex relationship with CANH best interest discussions. So when we are using Biozone, we're starting that exploration. So we need to be really clear that this is for assessment purposes only, if it is, and therefore we are providing no nutrition or hydration support. We need to be clear about the purpose of the intervention and shouldn't be biased by our own views. We need to remember that SLTs, we are key players in that kind of window of opportunity. So the time where the patient is formally nil by mouth and actually decisions around discontinuation of enteral feeding can and should be discussed. Our assessments are relevant and we should explore this as part of awareness assessment, but we need to keep in mind legal frameworks and move in an appropriate pace kind of in parallel with these best interest decision making. We need to share our knowledge and skills with the family and team as we undergo these assessments, clinically reason what we're seeing and being realistic in thinking about prognostics around eating and drinking, because that might be really relevant to somebody's quality of life in the future. So it's important that we kind of reflect and share with the rest of the team in a really nice kind of evidence-based and timely way. So we've put a few kind of useful links in terms of the PDOC toolkit, the SLT disorders of consciousness guidelines, and the PDOC guidelines there as well. Great, thank you.
That's it, thank you.
I can't see that. Anna, can you see questions? Let's have
Yeah, the question.
let's have a look. Hang on, let's have a look and see if they're PDOC ones. I think they're, yeah, they're from before. Maybe they're. No, I don't think. No. Someone asking, is there something you'd be happy for an SLTA to carry out?
Yeah, definitely. I think if they've had that adequate training, so we ensure that obviously our SLTAs, when they start with us, they have a kind of program of training anyway relevant to dysphagia and communication. Obviously anything an SLTA does is always under the guidance of a qualified SLT anyway, and actually it allows us to have that kind of intensity. So as we were talking about, doing it as part of an assessment process, which should always kind of be time bound and structured, so that we can really chart any change very clearly. They will allow us to kind of meet that regularity of exposure. So yeah, definitely something that SLTAs could carry out. Yeah.
I'm just really conscious of time. I want to be able to give all you guys a break. As I say, we will have time at the end for any questions. So if you do have anything else to ask specifically about PDOC, then please do pop it in the Q&A and we will get to them at the end. Somebody asking about accessing slides at the end. Yes, definitely. We will share the presentation slide with you. Absolutely. Okay, does everyone want to go have a break now for 12 minutes? If everyone can come back at about 10:40, we will continue then. See you shortly. Maria, are you there?
Yes.
Anna is just going to send you a quick email. Hi, everybody. We will make a start with our next talks. So now we have a talk from Rebecca and her team at the Lincoln Ashby Unit SLT team, and they're from Lincolnshire Community Health Services NHS Trust, and they're going to be speaking to us about the use of Biozoom in neurorehabilitation and share some case studies with us. Thank you so much, Rebecca, and everybody else in your team who's I can see there with you. Over to you.
Thank you. I'll just share my screen and hopefully this works okay. So that should be the presentation full screen now. So hiya, my name's Rebecca. I'm one of the speech and language therapists in Ashby Unit, and we've got Claudia and Lizzie here as well. Yeah. And we also have Katie as part of our team who's not here today. So we work for the Lincolnshire Community Health Services NHS Trust, but we're contracted in to work in the Ashby Rehabilitation Unit, which is based at Lincoln County Hospital. And we're going to be sharing a few case studies today. So a little bit more about our unit, first of all. So we are have previously been a level 2A, but sort of moving into a level 1B classification from NHS England's Neuro-rehabilitation unit, and we're based in Lincoln County Hospital, and we provide support for people who have acquired brain injury, other neuro-rehabilitation needs, and do have patients with associated spinal injuries. We can provide care for up to 2 patients with tracheostomy, and we do also support those with suspected prolonged disorder of consciousness and complete those assessments on our ward. It's an 18-bedded unit, and we are the unit for Lincolnshire. There is a community-based 2B unit in Lincoln, but otherwise in Lincolnshire there is very much not another unit for our neuro rehab population. So we do sometimes transfer out of county for if there are additional needs we can't provide. Very, very vague average admission there of 2 to 6 months. We generally have a maximum of 6 months with patients, and patients tend to stay for at least 2 whilst we have initial assessments, goal setting meetings, support family, and then arrange discharge as and when we feel that patient is ready. So we do really get to know patients and families well, because we have the luxury of knowing and working with them for months at a time, and we do key work patients as well, where we, for a selected number of patients, they have a professional that is chairing and kind of orchestrating their admission and making sure they have everything they need and that we're moving along well. And for 2 of the 3 patients I'm going to talk about today, we were their key worker, so we were very much involved with family liaison and overseeing their care. So how we got introduced to Biozoom, as many others, we attended the open lecture last year by RHN, and it came at a time where we were having a lot of discussions about how we support our patients who are nil by mouth for long periods of time, if there are preventative things we can be doing to prevent deconditioning, hypersensitivity, and how we support the motor or sensory impairments they may have in the meantime if they're not suitable for oral intake. We were also developing our PDOC assessments and interventions, and particularly interested in how we can provide and look into gustatory responses. And also reflecting a lot at the time on our management of risk with dysphagia. So what constitutes risk? Is it subjective to each person? How we make sure we are balancing that patient-centred care versus risk management, and not following predefined structures and pathways, but looking at each case individually to make sure we're doing what's best for that patient and what they would have wanted if they can't choose for themselves. And that will hopefully show in a few of our case studies. So we had a patient in mind initially after the open lecture, and we wanted to give it a try. So we were able to purchase equipment quite easily, weren't we? Agree with what others have said. It was fairly easy to buy and try out as part of our speech and language therapy intervention, first and foremost. So the first patient is a prolonged disorder of consciousness case as well. So this patient was emerging at the time and was presenting with significantly reduced initiation with verbal and non-verbal communication and motor movements as well, and was not consistently responding to stimuli. He was very fluctuating in his response to a dry or damp teaspoon, so perhaps would open his mouth to receive it but not close it again, or not show any sort of oral response to any stimulation that was on that spoon. So we were really wanting to explore sensory stimulation and also hopefully use oral intake or assessments to tap into functional object-based tasks as part of our PDOC assessments. So our normal management would be to, in this case, we did a cautious swallow assessment of thin fluid and a level 4 bolus. And in this case, it did pose risk of illness for the patient and aspiration, and also significant residue in the oral cavity. He tended to perseveratively just say yes after receiving something in his mouth and not make any move to manipulate that bolus. So it wasn't something we wanted to be continuing to provide with any regularity, only for assessments as and when needed. We were also very aware that we wanted him to be initiating or having upper limb support to self-feed, and to use a real bolus would have been quite difficult, and there'd have been a lot of spillage, and it wouldn't have really helped with those automatic self-initiation task-based movements. And a dry or damp teaspoon wouldn't have provided the sensory experience that we were looking for. It's just not quite exciting enough. So we really wanted to replicate eating and drinking as closely as possible as part of these assessments. So we felt like BioZoom would be a really good alternative, and we did have a try and use it with this patient. So we did find it did enable the patient to hold and self-feed with the spoon with upper limb support without the risk of sort of spillage, and it did have that visual bolus on the spoon, so he could see it, and we hope was motivated by that. It did help us to tap into that automatic routine of using a teaspoon, and he was able to hold the spoon, and we were able to look more closely about how he manipulated the spoon in his hand. We didn't have to worry about spillage as much, as I say, and we were able to look at dexterity, concentration, choice making, other things alongside his use of the BioZoom. It did seem to provide that sensory stimulation, and observations showed that he enjoyed it in terms of we saw lip smacking, oral movements, and other sort of indications that he was enjoying that and responding to it. And it provided practice swallows during that prolonged period of nil by mouth as well. More importantly, arguably, family had stated that to this patient, a key indicator of quality of life would have been for him to have a beer and watch football with his family. And we were able to achieve this in some way earlier on by having foam tasters of non-alcoholic beer. And it looked great because the foam just acted as a really deep beer head. So it looked very familiar, and I'm sure quite enjoyable for the patient as well. And him and his family were able to sit round and all have tastes of beer together, which was lovely.
And just that particular family, I know it was touched on the previous talk around expectations. His injury was absolutely significant, and he wasn't expected to survive, but he did. But his family's expectations, they've been really realistic throughout. And when we approached kind of BioZoom with them, and kind of when they stated in the first meeting around if he would get to the point that he could have a beer and enjoy the football with him, that would be over and above what they ever anticipated. So they were really understanding. And just very realistic that this wasn't going to mean he was eating and drinking again. This was a way to improve his quality of life at the time.
So overall in this case, it did provide, we hope, some preventative intervention whilst he was nil by mouth for decompensation. It was a doorway to assess object use, sensory awareness, and obviously boost quality of life in the meantime. And we still have the patient with us now, and he's eating and drinking a full diet, and fluids now having emerged completely from prolonged disorder of consciousness, which is lovely. So he's had non-alcoholic beer as a drink. So moving on to our second patient, this patient had an acquired brain injury and also a longer term tracheostomy, in that he arrived to us with a cuff tracheostomy with several failed attempts to wean or difficulty weaning. He had cognitive impairment and mobility impairment, and these were causing quite a lot of distress due to his reduced independence and difficulty communicating. He unfortunately wasn't able to engage in AAC or non-verbal means. He was very motivated to verbally communicate, but with his cuff tracheostomy, this was very, very difficult for him. As I say, there had been difficulty weaning. Most notably, he had a very large secretion load, which was very hard to manage medically. And a lot of the input he had was around trying to get hold on his secretion and repeated chest infections that were occurring. He did unfortunately require enhanced care due to the distress caused by a lot of his impairments, and of course his tracheostomy care. As I say, he had unreliable verbal and non-verbal communication at the time, but was making intermittent requests for food and drink and indicating his want for this. So at this time, any kind of breastfeeding was not felt appropriate to consider, but Biozoom was discussed as an alternative to try and support distress, quality of life in the meantime. It was used sporadically due to the variability in kind of how the patient was mood-wise and in his medical presentation as well. And he very much fluctuated in suitability for us to try due to motivation, sometimes requesting it, but then not actually engaging in having some. Secretions, of course, was a massive factor, and at times it felt inappropriate to either provide it or continue. So it was very much sporadic when we tried it. However, at times it provided really lovely moments of comfort, and the family reflect really positively on the memories of trying it with him. He had some lovely interactions around a table with family and staff, and would very often be asking or indicating, where's yours, or you have some, or pushing the cup towards other people. So it's really lovely that he was getting that social interaction and kind of leading on that as well, which fitted with his picture beforehand. We did have pina colada foam tasters on his birthday with family, which was lovely. There's a picture, I believe. And it is important to note that, as we say, secretions were unmanageable at times and distressing, and we did have to stop sometimes or go for suctioning. It's hard to say whether it was the foam directly that caused this, as at rest he was very, very much fluctuating in his secretion load. So it may have been his rest state, but it very much could have been that foam tasting, stimulation and saliva production. So just important to note, and either way it was very important to monitor, and we did stop at times as it would negatively impact his well-being in the moment.
And he was someone that, like you had said earlier, Erin, sometimes he would have had massive increase in secretions, and then the next day he'd go and there'd be nothing. So he wasn't consistent in the increase in secretions.
Just before I move on, a little context about how this case developed. So later on, the patient continued to trial cuff deflation, and it had a really significantly positive impact on his quality of life due to being able to voice, but it did lead to chest decline. So we actually had lots of best interest decision and conversations with family and the NDT, and it was decided family felt that it was in his best interest to trial cuff to stay down, as the positive impacts from his communication were so significant, it actually countered the risks they felt was posed, and there was a focus on maximising quality over quantity of life at this stage. They didn't want to pursue risk feeding at this time. They felt there was other environmental things we could do to try and target quality of life first, but it was sort of parked to revisit in the future if it felt appropriate. So there was lots of discussions about kind of quality of life, oral intake, and how to maximise that. So that's why it was felt that foam tasters, as and when it felt appropriate, were appropriate to continue with. And the patient has left our unit, and interestingly, it's the first time in our referral to another team we have mentioned Biozoom specifically as something we really strongly encourage them to consider reviewing and implementing in his new setting. But we aren't sure exactly how that will fall with him having a tracheostomy, whether it will require a trache speech therapy team or whether it can fall within more general brain injury community care, as it's dysphagia input, but not necessarily trache specific, but he has a trache. So we're interested to see kind of the limits on who can provide that in the meantime whilst he has his trache. So our main learning points from this case is that it is definitely a dynamic assessment of whether it causes someone distress or comfort, and it won't necessarily be one or the other. It may vary day to day or within a session. So it's important to note it may not be consistent. Due to the fluctuations for this patient, we didn't consider a daily plan of handing this over to staff or providing ourselves daily. If we had wanted to do so, we feel we would have wanted a lot more detailed discussions with the MDT and medical team about what we feel the cons and pros are, and the lack of research would have really impacted the ease of these discussions. Finally, as I mentioned today already, we really feel Biozoom provided a context for people to consider the risks and benefits of eating and drinking and acknowledge risks. So the coughing, distress, environmental impacts, secretion management, there are a lot of theoretical pros and cons to when we talk about whether to pursue risk feeding. This allowed us to actually see in practice how that patient responded. And interestingly, it wasn't always as we expected. It didn't always provide comfort, and it sometimes caused more distress. So it really helped put those pros and cons into perspective. And we think further down the line will really help the family make those decisions in his best interest if it's appropriate.
Just remembered while we were talking, that family in particular, I remember for a few weeks prior to us trying the pump, they were asking a bit around eating and drinking when that would happen. It seemed like trying the Biosyn for them to see it and see it working and see how it responded to it, almost like reassure them that it wasn't the right time and he wasn't ready to look at eating and drinking. And I think that was one of the real positives, was that it got them on board with seeing this is what practically it looks like. It's not a magic point that he's going to get to, that he eats and drinks again without any issues. Yeah, so it's just
and we'll just go on to our final case study. So this patient had multiple areas of infarcts, including a brainstem stroke, and as a result was experiencing severe dysphagia. So this patient had initially presented as locked in, was doing very well with physical rehab throughout a long admission, but from the very start cognitively was doing very well, and therefore was had capacity and was the decision maker in this case, unlike the previous two case studies. The patient had severe dysphagia. On video fluoroscopy, it was shown the swallow was triggering when the bolus was at piriform level. She had reduced base of tongue strength and weak contact of her tongue with the posterior pharyngeal wall. So she had a swallow rehab plan set. However, we were really struggling as the patient was unable to produce a swallow on command, and was really struggling with that trigger without there being a physical or a bolus in their mouth. And as we know, it's not appropriate to use a real bolus with many of these swallowing strategies. So we were very much wanting to look at Biosyn to help provide sensory stimulation to trigger swallows to allow her to access her swallow rehabilitation. And interestingly, at the time, the patient was already choosing to have teaspoons of clear water at acknowledged risk for quality of life purposes. So it was alongside that a sort of gateway to opening up those conversations around how she wanted to manage her eating and drinking at acknowledged risk plan, and to help her have boost her quality of life of trying different flavours that she was really keen to taste. So we trialled Biosyn during swallow rehab, and the patient self-reported that she really enjoyed it. She did try Bovril as well, didn't she, as many different drinks. And we had non-alcoholic gin.
Yeah, I didn't mix it with anything, which is a rookie error. So just make sure it's a gin and lemonade. It's very strong. She didn't like it.
So this sensory stimulation seemed to work. We were able to complete swallow rehabilitation exercises a lot more easily, and we're observing a higher frequency of swallows to be triggered. We had done thermal tactile stimulation with this patient, but she actually gagged quite a lot and had quite good sensory response to that. So we needed something in between. And from our observations and the patient experience, it worked very well for this. Provided more practice swallows, we expect prevented decompensation in that 6-week gap between the two video fluoroscopies, and like I say, contributed towards ongoing discussions around eating and drinking at acknowledged risk. And the patient then did start to trial period diet at risk, had no chest decline, and this gradually increased to where the patient was having full regular diet and thin fluids at acknowledged risk, and did not experience any chest decline despite the following 2 video fluoroscopies continuing showing silent aspiration. So really interesting case. This was the only patient we trialled with that was having Biosyn at least for some period every day or most days as part of swallow rehab. So we obviously didn't see chest decline, but she also didn't get chest decline from full oral intake. So it's worth considering. And just as the outcome, we saw significant improvement to her swallow on the second VF, although still at risk of silent aspiration on all consistencies. So, for example, the swallow trigger remained delayed, but was improved. Hyoid elevation and excursion had improved. Penetration was often reversed, although not always. And like I say, aspiration was still occurring. So just some final thoughts before we finish. So all 3 patients were observed to have positively responded or self-reported. Obviously, one was variable, as we say. We don't have any audit data on chest decline, very, very vague sort of observations throughout. We do agree it was easy to purchase, use, and also to skill share between staff members with clear instructions for use. We have found, therefore, it offers a tool for sensory stimulation, swallow rehab, lower risk functional oral intake and swallowing tasks, and increasing quality of life, alongside supporting those eating and drinking at acknowledged risk discussions. But we expect that in the future it will be a challenge having that lack of published information, particularly when transferring onto other units. We're looking into it in our critical care team as well at the moment, and expect that we are working on a stop in that setting because we feel it will be more required. But in our unit, it's been a lot more locally trialled within our team, and we haven't passed it on to any of the staff members that haven't needed that kind of documentation, risk assessment for them to follow. We're using our own clinical judgment at the moment when trialling it. That's us.
Ian, thank you all so much. They were just wonderful case studies. I think, you know, all three of them just really showing, yeah, some of the trials and tribulations and how it can, for some people, make a real significant difference. So thank you so much for lovely. So Zoe Gilbertson is one of our speech and language therapists here at the RHN again, and she is going to share a talk with us about using Biozoom on people with long-term neurological conditions. Thanks, Zoe.
Yeah. Right. Let's try the share screen. Hopefully. Can you see the slides?
Yes.
We can, but it hasn't gone on the slideshow. If you click on the slideshow button, it should try that.
There we go. Is that better?
Yes, perfect.
Great. Yeah, so I got across the RHN and used it in rehab and across some of our specialist services. And I'll be talking a bit about the specialist services side today, and thinking about EDAR versus flavour foam decisions and the range really of ways that people have incorporated the flavour foam tastes into their care plans rather than maybe a one or other choice. So the first is actually two case studies that I wanted to share side by side, because, you know, at first glance, they might look very similar. They were both in their 50s that have an MND diagnosis. Their care had become unmanageable at home as both became fully dependent for all their physical care, and remained cognitively very well. Both had PEG in situ before they were admitted. Both had been set up with eye gaze communication systems as well as low-tech systems. One had chosen the partner assisted AEIOU chart, and the other the ETRAN. One had elected to have a tracheostomy to manage their secretions and ventilation needs, and one stuck with the nasal pillows with quite high pressures at times, so was able to speak, however needed the AAC devices because of repeated chest infections or higher pressure needs that were causing real popping of air that made his speech unintelligible at times. So the first gentleman that had elected for the tracheostomy had some really young grandchildren that were visiting, and for him, prolongation of life and seeing his grandchildren grow up for as long as possible was really key in his decision making and about decisions in terms of his breathing and suction needs. The other gentleman had a couple of really beloved cats that unfortunately he felt would be too upset by a visit to the hospital. So we did arrange it home occasionally, but he was estranged from the rest of his family, and really not being in his home environment with his cats was a real loss for him. So the first gentleman opted for the Biozoom flavour foam. He really enjoyed it. It was with cuff down at times. He had some periods of instability where it wasn't so pleasurable for him because the vent would, when his vent settings had to be adjusted higher. So he had the team were happy to adjust the care plan if he was uncomfortable with his cuff deflated for the flavour foam. He still actually quite enjoyed it with his cuff inflated, but he didn't get as much of the flavour as you'd expect. So he had a variable care plan, depending on how he was that day. The other gentleman really didn't feel like the foam, he could taste it, but it didn't give him the mouthfeel that he was wanting. However, he didn't want to go completely risk feeding. It had a number of really severe completely to AAC, and he missed his ability to talk. So I found these tiny ice cube trays, and he had reasonable oral control to hold the ice cube on the front of his tongue, and there he could keep the flavor there for a while and get that moistness that he was really searching for, and that gave him the comfort that he was looking for, particularly from tequila and beer. They were his drinks of choice. It was around the holiday period, Christmas and New Year, so made him very happy. The other thing to mention was when first trialing by Zoom, we got some great feedback from both gentlemen, actually, that the metal spoons just really affected the flavor, and they ended up with a real metallic taste rather than the flavor of the foam. And a move to the well, we have a lot of maroon spoons, but plastic-based spoon was really helpful in keeping the flavor foam flavor. So I just wanted to bring those guys together because the pleasure and risk weighing up was really different for both of them for different reasons, although their sort of medical situation seemed to be developing on parallel for a while. They really made different decisions about their care and were supported to do so by the team. The next case study is a lady in her 40s who has diagnosis of Huntington's disease. Her care was no longer manageable at home, and she moved to the RHN and had been with us for a number of years. And as her condition had changed, she'd moved from a full oral intake toward, and then they had made a decision to go for partial PEG, partial oral feeding, especially because oral feeding had shown such joy. It had been a joy throughout her and her partner really enjoyed eating and drinking. She was still really showing signs of enjoying eating and drinking, but it got to the point where the end of the meals were becoming a real struggle. There was a lot of fatigue, then more coughing, and it was felt the balance wasn't quite right. Trying to maintain nutrition and hydration orally was making it not as enjoyable, even with all the input, from our dietetics teams around higher nutrition supplements and things like that. So in order to get a good balance of quality of life for her, she'd gone for PEG with some oral intake, and as time went on, the disease progressed and it was becoming more and more risk, and we were revisiting whether the balance of quality of life and oral intake was still right for her. So I was chatting with this lady was no longer able to communicate her own wishes, though we could see in her facial expression and behavior definitely behaviors that gave us an idea of what she was enjoying or not enjoying, but we were making a best interest decision with what we'd known of her and with input from her partner. The coughing had increased a lot during meal times, but she did love chocolate mousse and the chocolate supplements, and that still always turned towards it and took the chocolate above anything else. But the partner confided in me that what they used to really enjoy was wine together. And I was having a think about whether she could just have wine. Could they have wine together just as she had some of the chocolate mousse? But the partner had become so afraid of feeding her that they said that they just couldn't take it. It was so upsetting to see their loved one coughing that viciously, even though we had explanations around, well, that's quite protective, that's what's keeping her well. Yeah, she's still showing signs of enjoyment of eating. She could see how it was beneficial and was happy for it to continue with the staff, but couldn't herself watch it happen. So we had discussions around flavour foam and thinking about whether that was a way they could still share something they'd really valued and enjoyed without that real strong cough response that she found so upsetting. And it was a real positive outcome. It was something really joyful that they could share again together without worrying about causing coughing and distress. My fourth case is slightly different because this gentleman doesn't have a progressive disease as such. However, he did have a progression, a decline in his condition following several recurrent pneumonias, mucus plugging, and respiratory arrests. After several of these, so he'd gone from full oral intake, regular diet, thin fluids, again, something he really valued and enjoyed, to something that had become very high risk. And the recurrent pneumonias and respiratory arrests had led to an elective trachea and ventilation to manage his respiratory failure. So he was unable to stay in the long-term placement he had been in and was admitted to RHN for long-term care on the ventilator unit. A really supportive family and quite a sociable chap. So he could vocalize, but was unable to speak intelligibly. He could use his facial expression to give a positive sort of yes or no response to either symbols or objects, and certainly show us things he enjoyed or didn't enjoy. He had a cuffed tracheostomy, and as I say, was really quite sociable. And the family were talking about how meal times used to be like a really sociable and enjoyable part of his day, and that it did feel like a loss. But unsurprisingly, there was a lot of fear around his previous pneumonias, his respiratory arrests, even after his trachea ventilation. His saliva management had been really difficult, and he'd still had respiratory arrests post trachea insertion. So although they felt it was a real loss from the eating and drinking in terms of his quality of life, the fear over the medical instability remained the highest priority for everyone. And that's when we started talking about Biozoom Flavour Foam. Now, I have to say, when we first the lack of research was really problematic, and they felt that he was so unstable that it was not worth trialing. However, when we started to have some other patients with capacity who'd tried the Biozoom, they'd been doing it quite a while, they'd tried it with a number of patients, it gave all the staff team, from the medics through to the HCAs providing it, a lot more confidence that many people tolerated it and tolerated it well and took enjoyment from it. And that helped get a trial for this gentleman. And actually, he is using it now. It was a really positive social engagement. It's definitely something that involves choice making and interaction, and that he enjoys. So the Biozoom, it took us longer to get there, I think, to build staff confidence with other patients who were trachea ventilated, and the fact that he still gets enjoyment with cuff up as well, which again helps give people more confidence that things like any increase in saliva and things can be managed with trachea care, and a gentleman that has cough assists as well. So a best interests decision has been made actually now since the trial that it is something he'll continue with. So a quick run through, hopefully that's helped catch up a bit on time, but open for any questions.
Wonderful, thank you so much, Zoe. I'm just popping back on the Q&A, something's there. Anybody has
Oh,
anything?
I can see someone's asking
Are
how.
you staying on? Are you able to stay on?
Yeah, someone was just asking about how Baizu might prevent decompensation. This was in comparison to eating and drinking at risk. Yeah.
Brilliant. I think, are you able to stay on, Zoe, until the end of the, for the Q&A at the end as well?
Absolutely.
Excellent. Lovely, lovely. Okay. I'm going to have one more try at
Stop my
this
screen share. There we go.
video. Let's have another go. Thanks, Zoe. Right. I'm going to do it slightly different. Okay, so we've got one more talk to go this morning from Elizabeth Hepper again, who's going to talk to us a bit about sort of future research, really future research questions, and we'll go from there. Thanks so much, Lily.
Great, thanks again for giving me a second opportunity to speak to you all. And I just wanted to thank everyone that's contributed and shared discussions. It's just been so interesting hearing so many stories of people's experiences. And it's been lovely to see such individual kind of case examples and how real careful consideration has been with a huge array of introducing this concept with people. So I'm just sharing final presentation. Hopefully that you can see that now. So just to give you a little bit of background and steps moving forward from my point of view. So I'm currently undertaking a pre-doctoral clinical academic fellowship with the NIHR, and I'm supported by supervisors Joe Patterson and Mike Drinnan. And at the end of this presentation, I'll share where I'm at, but I wanted to take the opportunity again just to ask a few more questions and get a bit more interaction from us here about some of the related questions that I've been musing with as I've been trying to grapple with next steps for research. So if we're able to go back to Mentimeter, the link is still in the chat, and I'll share that page now and move the question on. If you wouldn't mind, start sharing your thoughts about what you think, what comes to mind. Oh, I'm not sure if it's moved forward for us. Yeah, when you think of the term nil by mouth. So just kind of whatever pops into your head. You might think of a certain patient or a situation, or kind of from your perspective. Thank you for all these words that are coming in. Got a range of things. We've got a lot of frustration. Got some of the physical symptoms, so kind of dry mouth. We've also got impacts on kind of quality of life and mood, distress, anxiety. So there are just so many things that as clinicians we kind of consider and think about when we're faced with someone that's nil by mouth and how we're trying to support these people. And I guess thinking about what we associate with eating and drinking, so kind of turning it on its head. Just stop sharing that for now and go back to my slide. What do we associate with eating and drinking? Also reflects quite a wide, I'm sure will reflect quite a wide range of things. So I've just got a few things that come to mind when I try to think of lots of different perspectives around just drinking. And I guess I'm kind of asking the question whether have we over-medicalised, or has eating and drinking for our patients become over-medicalised? So if we think of a patient that has kind of a condition that part of that means that they are needing to be nil by mouth. So far, a lot of our focus has been on meeting hydration or nutritional needs. However, what about the other aspects that someone might be left with after being told that they're null by mouth? And I know a lot of these things have already come up in discussions. So kind of a lot of talk has been around kind of the impact on socialization. The gentleman in the video talked about it kind of quenching his thirst and enjoying the taste. I know when I've worked with people, they've kind of talked a bit more about that routine. It might fit in with socialization as well. Kind of our day is often punctuated by meals or a morning coffee, and that kind of thing that holds a lot of other things in our day together. So if I take us back to the poll. Sorry, just bear with me. I'll move the question on. It would be great to see what your thoughts are. Do you think we have over-medicalised that, or whether it's we, do you think that eating and drinking has become over-medicalised for our patients? And that might be kind of something you've not thought about before, or want to reflect on a bit more. Might be thinking absolutely no, and that's okay. We do need nutrition and hydration to exist, so it's understandable why that's to date been the focus for us. So these are the numbers that are coming in now. Thanks for those that have kind of shared your thoughts. It's all anonymous, and it's just trying to capture maybe this group to help have an idea. So far, the people that have contributed, we've kind of got possibly leading the way. So it's maybe something that we don't know. And I'm not saying I've got any of the answers today, but maybe that's something that's the case. Some of you feel that it has become over-medicalised, and then there's some that aren't sure or no. That's really helpful to see. Okay. So then thinking about the areas that we need to support better. I know we did a brainstorm initially with a lovely word cloud that had such an array of things that we might focus our attention on moving forward. It would be great to see your thoughts from kind of a few options. So if we move on to the next one. Which areas do we need to better support patients? So this task, I think you can kind of rank how much of a priority it is on each one. So rather than saying that either yes or no, if you wouldn't mind having a go at kind of thinking how much of a priority do we need to support patients with these things, if that makes sense. You might feel it's hard to pick because lots of them seem important, perhaps. For others, it might feel quite clear-cut. Disclaimer that it's not an exhaustive list. So I was aware of limited time and also just what it's going to show us. So getting a bit of a mix. Lots of them are, I guess, there are a few comments feeling that we're doing an okay job, but the majority kind of these results are showing that we feel that there are things that we could do better. I think as most professions would accept, and that's what we're wanting to do. We're constantly, things are moving and changing, and we're constantly wanting to do even better for our patients. So it's interesting that kind of so far. Experiencing pleasure and taste again is kind of high up on what we feel that our patients might need. And feeling included socially, I guess that reflects a lot of the things that come up in our conversation today. Guess potentially linking to hunger and thirst, as that gentleman in the video has said. And I know there is some literature around kind of experiencing and thirst and kind of likening thirst to in comparison to kind of pain. It's quite a biological, physiological need that we experience. And for people that are nil by mouth, what that must feel like, but also whether that is the same over time, or whether that changes if you don't eat and drink orally. Okay, thank you very much for those. So I guess if we think about what the priorities might be, or the different areas, then it's how we capture that. So looking towards research, so I think case studies are brilliant, they're incredibly valuable. However, we've kind of recognised that there's a gap in the literature around these patient groups. And I guess kind of one of the challenges that I'm grappling with at the moment is how we measure and capture the impact. So it'll be great to hear your thoughts on maybe what you're currently doing. I know the R&D kind of or the RHN have provided some, or shared kind of how they're trying to capture that from their point of view. It would be great to hear what other people are doing, what tools people are using. Do we feel these tools are fit for purpose? Because I think often with research, outcome measures are such a key element. Kind of you're limited by the outcome measures with what you're able to investigate. Oh, I've realised that answers are coming in, but I can't see them on my screen. Sorry, bear with me and I'll see if I can get on the screen what people are sharing. Oh, I've got so many answers flooding in, thank you, but I'm afraid I can't work out how to show them on the screen. Have a minute, go getting them up. Well, I'm sorry I can't share. I need to get more familiar with Mentimeter. As I said, we'll make sure that we kind of share these poll results with you all afterwards, because you're the ones inputting to these for us. Thank you. And I'm sorry that I can't share all these comments. I can't even see them myself, so I can't read anything out.
Somebody said, Lizzie, on the Q&A, I think you might have to press enter to show the answers.
Ah, oh, thank you so much. Brilliant. Thank you. Wow, okay, so we've got a scroll here. I'll head up to the top. So yeah, patient feedback, quality of life rating scales. Thank you to whoever helped me, thanks. Yep, feedback, that's coming up loads, scales. Patient reported outcome measures, quality of life measures. I think that's something that I've been looking into. I am not aware of any patient reported outcome measures that capture people that are nil by mouth that might not have the expectation or anticipation to return to oral intake. So I know from a rehab perspective, that's always the hope, However, the reality is that that might not be someone's goal. And I know kind of the Eat 10, Swole Qual, there's a very heavy focus on eating and drinking again. So are the current patient reported outcome measures that we've got, are they fit for purpose?
It's almost impossible to find, isn't it, Lizzie? I know when we've been trying to write up our research here, when we were doing a bit of a literature search about people's experiences of being nil by mouth, other than people being nil by mouth for operations, obviously very, very finite time, or people who perhaps have had a neck cancer. There wasn't really anything other than that, and the patient report was extremely limited.
Yeah, exactly. And that's what I've been finding too. So thank you for those answers. I know we don't have time to go through those now, but I think that'll be really helpful from my point of view to help guide and make sure I haven't missed anything that people are aware of too. So I'm conscious of time. I'll move us along. One more. So future research priorities. So again, it's not an exhaustive list, but it will be really great just to kind of have a thought of where you feel the focus should be. So I kind of got a list. It's not an exhaustive list. It was very difficult to kind of limit them, but maybe kind of ranking from 1 to 8 with what your priorities are. Because I think it's something I've been grappling with, and it's so important to find the right research question to begin with. You normally end up with more questions than answers, I think, as I'm beginning to find. Currently, we've got impact and quality of life at the top. And that will kind of feed in again to making sure that we've got an outcome measure that we can capture with that, and whether before we're able to do more research, maybe the first step is to develop an outcome tool that we could then use. It's frustrating because it feels that might delay kind of the answers to the questions that we're searching for. But again, that's kind of necessary. It's another gap that I think I've found that we're stumbling across. There's lots of gaps in this research area. Great, thank you so much. I have one more question that feel free to just add in, kind of if there are any key interests you've got around flavoured foam, particularly things that I haven't covered, because it's not an exhaustive list. I've tried to get a range of influences for the work I'm doing, but it will be great to hear your thoughts too. So feel free to add those comments in while I'm just sharing a final thought with you. So one subsequent reflection that I've had from so far and delving into this research area is that there's undoubtedly such widespread interest in the concept of flavoured foam. So today's just an example with over 100 of us here to find out more. And I guess what comes to mind is, well, what does that tell us? Does it tell us that there's an unmet need for this patient group? And that's kind of the gut reaction from the clinician within me. But what does the evidence say? Is there any evidence, as Erin alluded to? I think it's really difficult and there's potentially limited evidence. Is this the only unmet need that we perceive as clinicians? How do we personally feel about working with people who are nil by mouth? I know that word cloud showed that there were kind of anxieties and frustrations, and I wonder if that was on behalf of patients or as part of that a shared experience for us as we feel as a clinician. How does it feel having the prospect of offering something to patients that we couldn't do before? So then I wonder, could there also be an unmet need as clinicians? Do we feel helpless, or part of our drive is wanting to do more for this patient group? And is that driving some of this interest too? It's hard for us not to put ourselves in the shoes of our patients and anticipating the difficulties and challenges that there must be for these patients. But is that kind of directing how we work as clinicians? Is that directing what we feel the priorities are for patients? As clinicians, we can often feel the emotional burden and left wanting to do more when there's minimal options. And are we jumping at the chance to kind of meet that unmet need for ourselves? I don't know, just a reflection. And could there be unintended negative results despite all these best intentions? Could it delay offering oral intake to these patients? I think there's so many questions left unanswered. And in the context of talking about how healthcare professionals evaluate risk and decisions, that's something we have to face a lot of the time. There's been reference to eating and drinking with acknowledged risk today. And I think there's growing literature around how we make decisions. And there's been a really interesting webinar by Sarah Robinson, an independent SLT, about that in relation to gender difference in relation to risk taking. And in this video, she reported kind of that females appear to be more risk adverse, and that's been attributed to having an emotional response in relation to that loss or things not going how we hoped. And given that the majority of our speech therapy workforce is female, is that potentially impacting on our decision making and the direction of future research? It was interesting that kind of very close to the quality of life priority, kind of understanding risk came a very close second. Is our way of making decisions around risks and managing them, is that impacting that or not? I can't go into all of that now, but it's really well explained in the YouTube video by Sandra Robinson. I think it's titled Risk Taking in Dysphagia Management. But as clinicians striving to provide patient care, this can be a really challenging concept. And I think someone else mentioned in their talk about that we need to be aware of our own potential biases too. It's a potential trap to fall into. So I guess going back to kind of the next steps from my point of view is that I'm currently undertaking a scoping review, which is looking into kind of the impact of being nil by mouth, and particularly the psychosocial impact, so that we can actually see what the existing evidence is. And so far it's showing that there's not much, and that I think it's going to be very challenging to measure, because I don't think there's an existing tool that can be used across studies. The intention is to better understand whether there is an unmet need for this patient group, which we have all anticipated. So there is likely to be one, but if so, where the priority lies, and so that we can guide and direct future research in this area. Once that's established, could flavoured foam be a vehicle for supporting people with some of these wider anticipated needs? So quality of life, experiencing taste, quenching thirst. Is that the only vehicle for us to use? Are there other vehicles? So many more questions. Hopefully that's given you something to reflect on as well, as I'm sure all these other presentations have. So thank you, and I want to thank you again for your time and all your input in taking part in these polls. And I welcome any questions or comments.
Thank you so much, Lizzie. That's really, really interesting. And I think you're absolutely, as I said, there's nothing out there about people's experiences who are nil by mouth, which really shocked me actually when I was trying to find it. I was like, where is it? It's huge, a chasm of just nothingness. So that's really exciting that you're looking to do some work with that as a starting point. I think our whole panel are here. So Zoe is still here, and Rebecca and Maria. So we'll go through some of the questions that people have been putting in the Q&A, and we can all kind of chime in. So if anyone has any specific questions for Lizzie, obviously pop those in as well. Somebody asked, this is an interesting question. Have you found any difference in terms of MDT comfort with Biozoom within the context of EDAR? So basically kind of saying that some members of MDT can be very unsure about supporting an EDAR decision, even when we're referencing like the RCP guidance and the SLT guidance that we now have, and that Biozoom could be a great in-between strategy. And they wonder if you found the MDT to be keen for this, given that it's perceived to pose a lesser risk and despite the sparse evidence base. Does anybody have anything they want to say for that, to Laura?
Just both of us working within a few wards in the hospital or across acute settings, I think it massively differs depending on where you are. I think in the medical wards, our medical teams tend to be quite pleased that we're taking a lead on what those decisions may be and how to go about exploring them, because unfortunately they're not that well versed or don't feel that confident with risk feeding decisions. So not necessarily getting any pushback there. It's more, yes, please advise us on what the options are and take the lead on that. But in our neuro rehab unit, particularly with trachea poorly patients, I think it's a lot harder sometimes to try and move away from that medical model of just leave them 6 months, leave them 12 months to see how their brain injury recovers, and then we'll talk about long-term risk behaviours. It's hard to kind of bring that conversation to a bit earlier, and not just say sit and wait, which isn't always in their best interest while they're struggling in the meantime.
Yeah, I'd agree with that. There's sometimes the want from the medical team to kind of stabilize, and that's even true for some of our patients with rapidly progressive diseases. Sometimes you know, if they have been unstable, they have had chest issues, really our role in advocating, especially if those patients using AAC and maybe those discussions have been really challenging, getting involved as speech therapists as the communication support as well for those complex decisions, and advocating when a patient does want to take that risk, whether it's EDAR or Biozoom. Actually, I think I've had similar responses for those really fragile patients, and you know, SLTs are really well placed to support the communication side as well as the, you know, the swallowing risk kind of benefit discussions.
One thing that occurs to me as well about Laura's comment is sort of Biozoom being good in between strategies, and we can present it to the MDT in a different way, because maybe it is, you know, although we haven't got the evidence for it, kind of logically thinking through what we're doing implies a lower risk for the patient in various sort of elements. But I suppose I'd always want to make sure that what I was kind of presenting was very, very person-centered. So not going for Biozoom because the MDT might be more on board with it, but actually taking it back to the patient, as Zoe just said, kind of having that, you know, advocacy role, etc., and finding out what they want, and actually what, you know, of these options, EDAR, Biozoom, what do they want to do? And yeah, kind of trying to advocate for that, really. Yeah. Lots of people asking about people's experiences in the community. So are there any services trying Biozoom in the community? I believe that there are. I don't know if anybody here on the panel has got direct experience of that themselves. I did try and find, so I put a shout out on Twitter to see if we could find specifically somebody working in community and somebody working with peds dysphagia as well. But unfortunately, we didn't have anybody sort of, you know, coming forward to speak today. Is anybody on the panel kind of aware of it being used in any services related to yours?
Yeah, again, one of the people that took part in the study, I think, said that their trust worked at acute and community. I think one trust found it challenging kind of making the service equitable across acute and community, and there's kind of different views and different challenges in terms of providing that service, kind of who's responsible longer term, how are they funded, all of those challenges. And I know another service, I think, was looking into kind of like a library option. I think that might have been for more neurodegenerative patients, but kind of, I think they were exploring that model. But I'm not aware of any services that, well, at that point, and that was a few years ago now, there weren't any established services, but I know those were the sorts of kind of challenges that they were grappling with.
So oh, sorry, go on, Rebecca.
I was just saying, we've been having discussions with our speech therapist in the community who's currently working within a PCN, and there seems to be quite a bit of scope, and she's very interested in trialling it. So she's based in a certain number of care homes within a primary care network. So on the Q&A, someone mentioned about dementia as well. I am not aware of anyone having trialled it in our trust with dementia, but in her role, she would be well versed to try it within those care homes. But I think, again, it would benefit from having that setting where you can educate and instill it in a setting rather than a general community home with carers popping in and out and things. I imagine that would be so much more difficult to get the right people in the room to discuss it and educate them.
Yeah, definitely. I think, I say, people have emailed us from community teams asking to share, you know, our resources and things, which we're very happy to do. But yeah, how far, so it's happening, but how far individual services have got with it, I'm not quite sure. Someone's put on the chat that they're in community and they're not started really using it yet. They've got a device and they're looking at it for their community MND patients, and they're going to do a bit of a pilot with it. Someone else saying they've started to trial it in the community in their trust. Recently, one of their patients bought it for themselves for quality of life, as they didn't have the direct funding for the local service within the team. And I think we've touched on this a little bit in some of the answers there, I think, and that's been a thread of kind of questions in the Q&A as well from people about funding. So somebody's saying here, many people have mentioned that funding has been straightforward to gain for BioZoom. Maria mentioned getting this via therapy managers. Has anyone else used alternative routes? Has it mainly come directly from SLT pot or other places where BioZoom is being used, e.g. a critical care pot? What are your guys' experiences of getting funding?
We did just do, I think, a local equipment request through our service lead, so it was signed off relatively easily. I think because of, as Maria said, the amount it costs is not considered a concern in the grand scheme of healthcare, so it was signed off very easily. I know that in our local 2B unit, the speech therapists knew of a patient family who got it funded through their kind of package of funding through CHC. I think they were able to include it in that, but otherwise I'm not sure, and I would expect in many cases patient families are just biting the bullet and purchasing it.
With the case study B, his family are the ones that are going to buy it, aren't they?
Yeah, they're looking into it.
Yeah. We've certainly had quite a mixture, I think, here at the RHN. So we have quite a large number of them as an SLT team that we sometimes leave on the wards for patients for trials and things if we're kind of handing it over. The ward managers are using their ward budgets at times to buy a few devices for the ward that can be used, you know, for different patients with infection control procedures in between, obviously. We did have a patient who was discharged into the community from here, and who was using BioZoom, and we managed to get the ICB to fund it. We had to put a special funding request through, but again, they accepted it because I think partly because she had a really good neuro-navigator who was on board and was pushing it through, but also because it is, as you say, relatively cheap in terms of an outlay to the ICB. But I think it's always thinking about who's then going to pay for the consumables, because obviously your sachets and your pipettes are single use, so you need to think about that. Although it's not a huge cost, there is an ongoing cost, isn't there, associated? Yeah, people saying they've used their trust charity for funding. So various people sharing that their trust charity has funded a number of kits for their service, which is amazing. Yeah, as a starter kit isn't that expensive. We've managed to buy a few from the SLT budget. My project will hopefully provide evidence from patient feedback refunding. I think it's quite a mixed picture, isn't it, really, even within a service, because we again got patients here where families have bought it, you know, or the patients bought it themselves as well. So, you know, to use on an ongoing basis. I think it's a real mixture, isn't it? But yeah, definitely a consideration of is it sustainable? Just looking back for any other questions. Are there any BioZoom leaflets people have used to share with patients or families? Has anybody developed a leaflet or a patient information sheet in their service? We don't have one here.
We got leaflets with instructions on how to use it for patients that are independent to use it, or if we've provided to the family and they can use it with them. But we haven't got anything else, but interested if other people have anything and they're willing to share. That sounds great.
Absolutely.
I print out the photo guidelines from the BioZoom website and put them with families, and staff will find that really useful. And then just put our own infection control protocol on the other side.
Yeah, always handy. And we also have meal mats here as well. For everybody who's eating and drinking orally has like a laminated placemat with all their guidelines on it. And we do one for all of our BioZoom patients when we're handing it across. Somebody that's going to have it on an ongoing basis, we'll make them a meal mat. And that has, advice for them. And on the back, it has the process for making it and sort of just some general tips really and things to be cautious of.
That's where we put the specificity of the individual as well.
Yeah.
Spoonfuls, how many times a day, if they require oral suction, things like that.
Yeah. Someone saying from an acute setting, we're linking closely with the medical team when we're starting oral intake with patients that have severe dysphagia. How did you introduce BioZoom to the medical team? Was this on a case-by-case basis, or did you organise a training session? Have you experienced any barriers from implementing BioZoom with patients that you feel would benefit from it, but the medical team disagree? We've been quite lucky here, I think, generally speaking, with our medics. Anybody else?
I think it was a slower process with the most fragile patients. So the gentleman that had lots of pneumonia, respiratory arrests that had obviously caused a decline. That was probably our trickiest case. But over time and with experience with other vulnerable patients, that made it easier to have those discussions with the medics.
I think for us, initially it was kind of managed in a similar way to if we would recommend oral trials. It was just something that we clinically reasoned and recommended, and the medics didn't really question our kind of clinical judgment in that case. As I say, with the trachea patient, where there's an obvious reason that patient wouldn't normally even consider eating and drinking, that's when it was more of a detailed conversation. But we've not trialed it on our medical wards, generic medical wards, but I would imagine it would be very difficult just because you don't have as close links to the doctors and the teams there. So that our colleagues who manage the medical wards in our hospital, I think it would be really tough, as you say, whether you want to have training sessions or how you educate or skill share to the nurses who would be providing it day to day. Even in our quite nicely controlled neuro rehab unit where we have our own little village, we're still kind of going back and forth as to whether we can or want to hand that over to nurses at this stage, and how we would capture enough of the staff to make sure there's people confident with when to use it and how. But we're at risk of overcomplicating it as well because it's a relatively simple process. So it's really interesting.
Balance, isn't it?
Yeah, what people are doing.
Marie, I think you shared that you did some events like and sort of swallow awareness day and things like that to try and promote people's understanding of it as a hospital.
So we had like a trolley and we had the BioZoom there. So wherever we would go on the wards, we would ask people to try it. But anytime we also do it with the patient, we check who is here, are the doctors here, can they come and see how it actually works? Because obviously they don't know what it is. And I think it does depend on the person sometimes as well. But we do take it on a case-by-case basis, and we just have a chat with the doctors if we're not sure what are the pros, what are the cons here, and what can we do for this patient.
Yeah, absolutely. I think we've run out of time there. We've slightly gone over, but I think there were some really, really good questions. We haven't managed to get quite all the questions, but I hope that some of the ones that we've missed kind of from earlier on, we've kind of covered to some extent in the talks that have happened subsequently. I just want to say thank you so much to everybody who has spoken today. Everybody's been absolutely amazing, and they've given up their time and shared all of their learning and expertise and experiences with this for the benefit of all of us. So just to say huge thank you, and we're really, really grateful for that. And it's been I've certainly found it incredibly useful, really interesting to hear how different services are using it, and what some of the kind of research questions might be for the future around all of this, and go from there. So yeah, thank you very, very much. And thank you to everybody who has joined us as well. It's hopefully